Hello, everyone, and welcome to another episode of the Everyday Leader series. I'm your host, Dr. Ananya. My guest today is an accomplished associate professor of health systems and policy with deep expertise in healthcare, financing, and implementation research. He holds a PhD in public health from Seoul National University and has led transformative work in community based health insurance policy reforms, and health systems strengthening across Ethiopia and beyond. As the founder of the Health System and Financing Research Center and a former chief academic director at University of Gondar, he has shaped national research agendas and mentored emerging public health leaders. His global engagement includes consulting for Harvard's PHENOT project, training in Rwanda, Ghana, and South Korea, including the US, and he has collaborated with WHO, Vital Strategies, and Coffee. A recognized leader in his field, he serves as a vice president of the Ethiopian Health Economics and Policy Association and was honored with the University of Gondar Best Mega Project Research Ambassador Gold Medal in 2022. Dr. Asmamo, welcome to the Everyday Leader.
Thank you, Dr. Ananya. It's a pleasure to be with you.
Yeah, it's great to see you. So we're on the Everyday Leader series, and we have a traditional question. What does the everyday leader mean to you in the context of your expertise or your area of expertise?
Thank you so much, Dr. Ananya. Yeah, this an everyday leader for me is that, uh, a leader with, who inspires, uplifts us, and who influences, others while working with them, and who, an everyday leader can be a male or a female, so that who inspires, influence, and help others to achieve, their objectives, their intended objectives of their specific task. So I feel that an everyday leader is the one who can influence, who can aspire, who can share his experience, and who can help others in his everyday activity.
Yeah, that's great. You're right. It's an everyday thing, right? As a leader, you don't get a break, although you
Yeah.
wish to get a break, you don't get a break. So that's you put that fantastically. So we're gonna narrow down to your area of expertise, and there are people probably listening or will be listening to this and wonder what is health economics and why is it important to understand that concept?
Thank you again. Economics in general is it emergent, emerged or emanated from, two basic terms: scarcity and choice. Globally, we are living in a world with very scarce of resources. So scarcity is there. But we need to make, a very genuine decisions. So economics in general is the science of, making genuine decision while resources are very limited. That is the general term everybody should understand when we think about, economics. When come to, and there are many principles to make, decisions on scarce resource in order to achieve our needs or our goals. So the use of those specific principles and the concepts of economics in health We call it health economics. And health is a very unique thing that we have in the world, and it's really quite difficult to trade or to make exchange of health in the normal market because healthcare markets are not, needs the management, regulation, and the stewardship of the government. So, health economics, in short, is the use of economics principles in
Mm,
health to make more health more, affordable, accessible, and
mm,
finally, it should help us to achieve universal healthcare coverage. So
mm,
that's how I define, health economics. We need to start from, the scarcity of the resources. Resources towards the health system is very scarce, so that we need to prioritize. We need to make, decisions on the health system. For that, we need to have the knowledge and the skill of economics.
mm. Interesting. You know, I mean, I'm guilty of this as well. When you work as especially just a clinician, you only see your day-to-day interaction with patients, and it's you do see the effect of health economics, health financing, policy, and everything. It affects your day-to-day practice, but you never really stop and think, where can this be changed, or what can be changed, or what can be influenced, right? So we're everybody's affected by it. The patient is affected by it, the provider is
Yes,
affected by it. Collaborations and partnerships and everything, those are resources. So everybody within the system is affected by health economics. And I think it's very important for everybody to understand the relevance of health economics, and that we cannot do without it, without understanding what it is and how it works. And I love that you mentioned it's about scarcity, because scarcity is everywhere. And whether you're in a first world country or a third world country or in a developing country, there is a
that's true.
scarcity of some sort, right? So it's very interesting, to see that it is about scarcity and how, like you said, to manage that scarcity. Um, so in everything we do, and you mentioned earlier, leadership is very important, right? So how, in your view, what leadership traits are essential navigating the health economics, especially in a resource constrained setting, like our country?
Yes, thank you, Dr. Amania. Yeah. As I mentioned, and as you also, capitalized, we're living in a very resource limited world, not only the low income country, but also, uh, even I know the magnitude is different, but the resources are very scarce around the world. But when we come to, the low income country, the magnitude is very severe. We have, a very high scarce resource coupled with other problems. So in that case, there are multiple uh, leadership traits that we need to have to manage the resources and to achieve, the intended objectives of the health system. Because, in the health system, we have three big goals that every health system,
Mm,
whether in developing country or in developed nation, we need to achieve, we need to make sure or improve the health of the population, the entire, and the health system should be very responsive to the needs of the community. And we need to make sure that the health systems are, financially responsive too, because we don't need to push peoples while paying some amount of money for healthcare utilization. Because in many developing country, peoples are paying a very huge amount of healthcare expenditure, and they pushed below the poverty line. So these are the three basic uh, objectives of the health system. So that, healthcare financing comes here, health economics comes here. In general, some of the traits, the leadership traits should be, we need to have a very strong system thinking.
Mm,
We need to strengthen, the system. We need to think smarter. As I mentioned, we have a very limited resource, but we have full of challenges. So we need to think about at the system level. System thinking is very, very important one. Without, system thinking, we are unable to achieve the health system objectives. And even to manage the resources in order to achieve the objective, I think evidence-based decisions, our
mm,
decisions should be based on evidences. So clear evidence, clear data is very, very important. And we need to be very, resourcefulness. We need to have informations. As I mentioned, to manage the system, to have a system thinking. As you mentioned, uh, the health system, uh, as WHO clearly outlined, we can classify, or we have like building blocks of the health system.
mm,
The WHO put six building blocks. So health service delivery, the one you mentioned, the clinical service and others is one of the health system building blocks. And healthcare financing is the other building blocks. The human resource for health and others. These are the health system building blocks. So that we need to think about at the system level rather than at individual program levels because we have a very scarce resource. So system thinking, resourcefulness, evidence-based, these are some of that. There are many, leadership traits, but and we need to think about, equity-related issues because
mm.
in many developing countries we have several disparity issues, urban rural disparities, sex-based disparities, and other disparities. So equity is one of the main important issues. So as a leader, we need to think about, how we can be fair enough in managing different parts of our, community. And efficiency is another threat because we need to think about we have a very limited resources that as a leader we need to think about within the given limited resource how we can achieve a maximum output. So these are some of the leadership traits that we need, and while we are managing a health system or while we are working in a higher education institution, we need to have such a kind of leadership traits. So these are some of the traits I believe we need to have as the basics.
Yeah,
Thank you.
that's great. I love how you put that. Very it was very systematic how you went down the list. And what stood out to me is system thinking. System thinking. That's that feels like the highlight of the most important threat for a health economy leader. Um, so is that strategic thinking, does that come naturally? Is there something that people need to do to practice it or to learn it? How do you achieve that strategic thinking?
Yeah, it could come, inherently, but it needs really to understand the situation. It needs, uh, it's a kind of learning process for me. You should understand the health system. If you don't understand the health system, you cannot strategically think about the health system. So I feel it could come inherently, but it needs some sort of, learning process, and it comes through, experiences, and it should come from, it comes from, from your learnings and from your experiences. For me, when I was before I attended my PhD, I was not able to understand what healthcare financing means. But when I went to South Korea, the country with a very strong healthcare system, at the early periods of my study, it was really, quite difficult for me to understand what real health system means and how I can understand healthcare financing within the bigger healthcare system. Because strategic thinking or this system thinking needs to, you need to understand the health system because without understanding of the health system,
I think we've lost connection. Yeah, I think we lost connection there for a minute. Can you hear me? Can you hear me, Doc? Okay.
Yes, yes, Dr.
So we
Rana.
were talking about how to get that strategic thinking, how to develop that strategic thinking trait, and you were talking about your experience when you were in Seoul, Korea. So
Yeah, just to finalize that part, I think uh, we can this strategic thinking or this strategic leadership or those related issues of leadership trait can be learned inherently. But what I feel is that it's a matter of experience, and it's a matter of exposure, and it's a matter of the understanding of the over how the overall health system is working, because as I told you, the health system is within the country's other social policy frameworks. We sometimes feel that the government should increase the budget to health, but we should think about the economic status of the country. That's one of the knowledge that we need, because that is a system where the health system is a very complex system within another complex system. The health system by itself, if you take the hospital, that's a very complex system, even the hospital, but that is within the bigger health system, and that's within the country. So that I think strategic thinking or this strategic leadership is very important, so that understanding of the system, the overall the system, understanding of the country's economic, political, and other related issues is very important. But once we understood that, we should have a very clear understanding of the health system, how it works. Even sometimes we may have plenty of resources towards the health system, but we fail to manage that resource. We don't know, a short-term investment or long-term investment is very important in the health system, because health is a kind of a very long-term investment. In the hospital, you can see, you can do a surgery and you can see the outcome of the patient. But as a health system, one of the objective of the health system is improving the health of the population. That's increasing the life expectancy, decreasing the morbidity, decreasing the mortality. That's those issues. The inputs are some of the inputs are beyond the health system. To make the society healthier, I think that's beyond the health system. So that kind of thinking, that kind of knowledge, that kind of exposure is a very important trait for the health system leaders.
interesting. Yeah, you're right. It's not something that exists on its own, separate from other things.
Yes.
So that makes sense. You really have to take into consideration about everything that's going on. Um, yeah, I would have loved to go deeper on that topic because it would be very interesting to see your perspective from a first world country like South Korea and their health system versus an African countries. Um, some have made immense progress in the past few years, but still there's a lot of work to be done. So, um, comparatively, do you think it's that health, like system thinking and resourcefulness, are those the things that make the difference between why that health system is developed as it has and the health system we have hasn't developed yet? Do you think which things are the most important factors? You think? This is a broad question, I know, but just try to give us like a couple of points.
You mean between system thinking and
No, between
resourcefulness?
like the health system in South Korea and the health system, for example, in Ethiopia. What has made that difference? What things do you think made that difference between those two health systems and the health economies?
As you priorly mentioned, we are in a different level of development. As a country is more developed, they can, push more resource to the health system, and they have more, educated peoples to manage the health system, and even the society is more responsible. You know, if you take the healthcare seeking behavior between Koreans and Ethiopians, they have a very high healthcare seeking behavior, which is really very helpful to have very healthy and productive society. And the health system arrangement is quite different. In a poor country like Ethiopia, we have more. Um, we don't have sufficient number of health workforce to provide even the basic health services. We are trying to provide the basic health service through the health extension workers. But a country like Korea and other developed countries, they have high level
Mm,
professionals to provide the basic health services. So that I think we're totally different in many ways, not only the system thinking and resourcefulness, but even for developed country, strategic thinking, resourcefulness, evidence-based decision making, and others are very important for them, and it's important to us too. Though the degree is different, so the status is different, but these leadership traits are very important for both developed and uh, developing countries. That's my thinking.
yeah. Yeah. Um, so, what are the most pressing financial challenges right now facing Ethiopia's health system? And you've had exposure to other African countries as well. Is it similar to what you see in those countries, or is it peculiar to Ethiopia?
Thank you, Dr. Anania. I mean, many of the developing countries, including Ethiopia, when we see the healthcare financing landscape in general, you know, uh, we're highly dependent on donors' funding and individuals' out of pocket payment, which means healthcare expenditure at the point of healthcare service use. And when if you see the Ethiopian National Health Account results of the 2021, uh, like the government expenditure was around 30%.
Mm,
Donors was, I mean, government was 33 point something, and household expenditure or out of pocket payment was around 32, and the donor was around 30, which means more than 50% of the healthcare expenditure is from the donors and
mm,
the household out of pocket payment, which is really a very huge amount of resource which comes from from donors and from the household. That the household expenditure really that leads the individuals for very catastrophic healthcare expenditures. If the healthcare expenditure is above some amount of threshold, we call it like catastrophic healthcare expenditures. So when we see that kind of figures, I think the Ethiopian health system was highly reliant on donors funding and individual out of uh, pocket expenditure. That's common in many African countries. But the challenge now is, donors funding has been declining since the last 3 4 years, and recently there is a very huge reduction of donors funding towards low income country like Ethiopia. So now the country is facing, this donor funding reduction, and it really affects us also the household out of pocket payment, because if the donor funding is, reduced, individuals will be responsible to cover their healthcare expenditure. And Ethiopia and other low income countries, we have had, Abuja declaration, that the Abuja declaration said that many low income countries should allocate 15% of the yearly government expenditure towards health. But when you see the Ethiopian, recently we I saw a figure in a report, it's around 7.5% of the government expenditure is allocated to the health system, which is half of the Abuja declaration. And the WHO recommended low income countries at least to have, 86 USD per capita expenditure for the individuals at $6. But the Ethiopian is only $36. We are very far from, the standard set by the WHO. And this could be very common for other African countries too. But there are some countries that significantly, improve the government expenditure, and they try to, liberate the health system from donor dependency. So the pressing challenge for Ethiopia could be, this the reduction of donor funding. As I told you, it was around 30 to 32%, which was a very huge amount of money. And we have a very, comparably a high amount of out of pocket payment. And we have, a very fragile healthcare system due to different reasons. We have some sort of internal conflicts. We have some sort of, natural disasters. So this all could affect, the healthcare system and the domestic resource towards the health system. As I mentioned, the government's uh, expenditure towards health is somehow low when compared to, the standard. So these are some of the pressing issues. So this could affect, the health service utilization of some of the basic healthcare services like the maternal, child, neonatal healthcare service, SRH services, and some of the infectious diseases. And overall, the Ethiopian healthcare system is facing a triple burden of the disease now. We have the infectious disease, we have the non-communicable disease, and we have a very high rate of, these injury and accident related issues. So we are facing a multiples of disease burden, but we have a scarce resource. This is the second one. The third one, though, we have a very reduced donor funding, low government expenditure, we have a very high inefficiency of the health system. We are not really efficiently utilized the available resources, not only the financial resource, but also the human resource and other material resources. So that, our health system is facing multifaceted problems, not only, reduction of donor funding, but also, as I mentioned, we are facing a triple burden of disease. We have a very low human resource for health, not only for the physician, but even for other mid-level healthcare professionals. We have, below the standard for the WHO, and we have inefficiencies in utilizing the available financial, human, and other material resources. So these are some of the pressing issue that our health system is facing, and these are common in other African countries too.
Mm. Wow. A lot to think about from what you just mentioned. There are so many factors coming in affecting, the health system and the health finance, and you do see it every day if you're in the system, but you wouldn't understand it the way you just described it. So thank you for clarifying that and giving us like a wider lens on how to look at things, right? So it's very interesting because our healthcare system is bleeding from every side. It's like filling a balloon with water and pricking the balloon everywhere, right? It's just
Yeah, yeah.
bleeding from every so many different directions. And yeah, to your point, I do agree. A lot of African countries would have very similar challenges, um, and I think that's why we think we have to come up with like the Abuja Declaration or under the AU umbrella to really find Pan African solutions to problems, because there are so many resources that are, like you said, that are available but not used efficiently. So maybe if we can come up with a partnership between countries that have some resource that is, a resource in a certain area more than the other country, then coming together and approaching it that way might might actually answer some of the questions that you mentioned. So you mentioned about health expenditure, and most health expenditure in Africa and Ethiopia are 33 to 35%. That's a large number is out of pocket, right? And that's where community-based health insurance comes in. So can you explain what community-based health insurance is?
Thank you, Dr. Anania. Yeah, yeah, that's a very huge number. But you know, before like hello, okay,
Mhm.
it was bigger than this even before like 5 6 years. It was around 40 45%, but through extensive reforms from the Ethiopian government and other partners, who were able to reduce the out-of-pocket payment and the dependency on donors. And I think it's significant. The government expenditure is significantly increasing, though it's not sufficient enough. So coming to the CBHI or community-based health insurance, this is a kind of resource mobilization, or I would say, because insurance is one of the way of uh, mobilizing resource. When we say healthcare financing, there are three main functions. One is mobilizing resources from multiple sources. Then the mobilized resource has to be pooled, and the pooled resource has to be allocated, or it has to be paid for the providers. These are the three main functions of the healthcare finance. So while there are different ways of mobilizing resources. It could be from the government tax, it could be from donation, and it could be from health insurance. So since the 1990s, many of the low-income countries in Africa, they started to have a kind of insurance system. This is a kind of prepayment modalities. Individuals or communities are supposed to contribute a regular amount of contribution, whether they are sick or not, and they can use that mobilized resource when they get sick, and it really helped the community not to push below the poverty line, and it really minimize the out of pocket payment. So this community based health insurance is a voluntary kind of health insurance. It's a voluntary. But some countries like Rwanda, they make it mandatory and they're very successful. So, community based health insurance is a voluntary based health insurance, and it's supposed to be managed by the community by themselves, and they have a regular uh, contribution or premium. Within that regular contribution, they have a predefined benefit package to be used from the healthcare facilities. This is what we call it community-based health insurance. I think different countries they gave a different name, but in Ethiopia it was started in 2011 as a pilot in three regions with 13 districts or waradas. It was piloted before 14 years ago, and recently I think it's been scaled up to more than 1,000 districts, and it covered more than 50 million Ethiopians, or around 12,000 households, and it showed a significant improvement in out-of-pocket expenditure. There are studies that shows that CBHI members have a lower out-of-pocket expenditure compared to non-CBHI member, and studies also showed that it improved outpatient health service utilization compared to the non-CBHI member, and it laid a foundation for Ethiopians to have a kind of national health insurance in the future, because recently the government of Ethiopia has been thinking to implement social health insurance for the formal sector, and the CBHI has been implemented for the informal sector, mainly for the rural community. And I think before 1 year or 2 years, they make it mandatory, because as I told you, CBHI is a voluntary based health insurance, but recently I think they make it mandatory, which is really a very important strategic decision by the Ethiopian government, to have that kind of strong health insurance system. I think this is what CBHI means, if I answered this question. Thank you.
Yeah. Yeah, thank you. That was an excellent explanation. And um, I put out a poll actually the other day asking people where they see the challenge has been when it comes to community based, health insurance. And most of them say the healthcare is not ready. Like, the healthcare system is not ready for it. So I want to hear your take. How has the uptake been so far, both on the community side and the government side?
Yeah, no, thank you. Yes, um, while a country is implementing health insurance, or I think you would have the chance to read the WHO cube. We have a WHO cube. If you see the WHO cube, that's really how countries can achieve universal healthcare coverage. And that's really, we used that cube to show health insurance achievements too. In health insurance, we have a population coverage, that's the enrollment. The more people you enroll, I think that's good for the population, because you are providing a chance for the population. But there are two issues in addition to the population coverage, that is the service coverage and the financial coverage. The more people you are enrolling to the insurance system, you need to have more resource to provide more service for the population. So far, the Ethiopian health insurance system is very successful in population enrollment. They try to mobilize, populations, more population to join the insurance system. But we still have some sort of challenge in service coverage and financial coverage. So, in the lens of the insurance beneficiaries, it's really very successful. But there are some remaining tasks from the provider perspective, because while we are implementing health insurance, healthcare providers, both the institution and the professionals, they are expecting, some sort of incentive and additional resources to improve the healthcare system. This has been a point of discussion with different, stakeholders like the government and other stakeholders. And in many developed nations, while they are implementing insurance agency is, an autonomous organization,
Mm.
and the insurance agency should be responsible for, purchasing the health service, and there has to be, an autonomous agency or group to provide the service.
Mm.
In many developed countries, I think both and the health system or the healthcare organization as a provider, they are under the Ministry of Health, which is really, we don't have a split between purchaser and provider. That is a
Mm.
challenge, because the providers would want to ask question, but their question goes to the Ministry of Health.
Mm.
The purchaser, the insurance have a question, but that question also goes to the ministry. That's one of the main challenge. And the other question that you raised, the health system in general is not ready. I think there are issues, and we have evidences in that regard. I think health system readiness is somehow low to implement health insurance, but the government is, rigorously working to make the health system more ready, because recently they are planning to implement the social health insurance. They accept that critics, they accept that challenge. Yeah, the health system is not in a position that we want it to be, to implement the health insurance. And there are some other policy related issues, as I told you, the provider payment modalities. So far, we are paying, the health professionals the monthly salary, but the provider payment modality has to be changed, so that the health systems needs to be very ready. I think this has been a point of discussion by the Ministry of Health, the insurance agency, and the different healthcare organizations in Ethiopia. But I think your question and concern is
Yeah.
valid.
Yeah. Wow. Thank you for that enlightening explanation. It's just so multi-sided, and everybody has every entity involved, whether it's the ministry or the healthcare providers or the hospitals. They all have some sort of input in all of this, and but like you said, there is no split. I think one of the keys to success to health insurance in other countries, in developed countries especially, is that there is a clear split, like you mentioned. They're in under different umbrellas, although there are certain insurances that are still provided through the government. But the split is clear, like you said, and I think it comes back to efficiency. If you have one umbrella trying to manage everything, there will be more inefficiency compared to different entities overseeing particular parts of the healthcare financing, which just makes it more successful. So, my next question is actually related to a question by one of the audiences. Dr. Helena, she says, in a low resource setting, what innovative financing strategies have you seen make the biggest difference in strengthening health system reliance? So, innovative financing, especially now that you mentioned that there has been donor exhaustion, and quite a significant part of the health finance budget was, donor donations. So, what innovative financing opportunities are there right now to fill that gap?
Thank you. I mean, that's a very interesting question. I think it returns back to the domestic resource mobilization. I think we need to work on, domestic resource mobilization, which has to be coupled with, efficient available resource utilization. As I mentioned earlier, we can mobilize more domestic resources, but efficiency has to be there because we feel that many of the developing countries, including Ethiopia, we have a very low efficiency level or efficiency rate while we are utilizing the resource. Some of the innovative financing issues. The Ethiopian government, even before the reduction of this donor funding towards the healthcare system, the Ethiopia government has been working on different innovative healthcare financing modalities, and one was the health equity fund. It was a thinking from the previous leadership of the Ministry of Health and other healthcare financing professionals. And even recently, uh, my friend is like Dr. Girma, he's a health economist at the FNOT project and a senior healthcare financing advisor for the Ministry of Health, Her Excellency Dr. Magdas Daba. We have been working on some sort of innovative financing, like to have some sort of earmarked taxes from excise or sin tax. In Ethiopia, there's a very high use of alcohol, different alcohols, like it could be factory processed alcohols or it could be local alcohols, and we have a very high group that use chat every day. And we have been doing some sort of research to show the effect of this excise tax on alcohol and tobacco utilization, and we try to model the expected uh, revenue from excise tax. And as an innovative financing, we have been advising the government to allocate an earmarked resource from alcohol, tobacco, and chat taxes. We know still discussions are going on, but our friends, they have been establishing MOH and Ministry of Finance team to work on some sort of innovative financing, and they have been visiting the Philippines and Indonesia. The Philippines, they have a very good example of earmarking of these excise taxes. So we have been working in that regard to have some sort of innovative financing in order to make the health system more resilient amid this ed cut. And there are some other initiatives like the public-private partnership activities, because the private sectors, they have the resources. I mean, the government, we have the resource, we have the physical space and others. The private, they have the materials, and there are some ongoing discussion and some specific activities with some institutions to have very strong public-private partnership, so that we can obtain some sort of resource which can support the healthcare system. That's another issue. And there are some other innovative financing mechanisms to support the healthcare system, in addition to increasing the domestic resource mobilization, because we are pushing the government to increase the budget allocation towards the health system. That's the traditional way of increasing the budget to the healthcare system, but we wanted to show them how they can mobilize more resource from the excise tax. As I told you, we did a research, and we tried to show them how they can mobilize more resource, but we wanted, some amount of that resource has to be earmarked to the healthcare system. These are some of the innovative healthcare financing mechanisms which are in the table of, the Ministry of Health and the Ministry of Finance to improve the healthcare financing while there is, this donor funding reduction.
Yeah. Wow, it would be very interesting to see the outcome of that. Those are great ideas. I mean, on paper, they sound good, but when it does come down to implementation, I hope they would be as effective as planned.
Yeah.
So just to piggyback on that, equity is one of the goals, right? So how do you balance? You're trying to increase your input, right? The money that's coming into the healthcare system and health financing. So how do you balance the cost containment with expanding access to essential services? Because if we talk about equity, one of the most important parts is expanding access. So how do you balance that?
Yes, that's one of the challenge, that many of the health system has been facing, including the Ethiopian healthcare system. In our, first discussion about this leadership trait, about the strategic leadership, the strategic thinking, it comes here because it needs to strategically think how to really contain costs or how to improve efficiency. Because in economics, there are trade-offs between efficiency and equity. Because equity is fairness, but efficiency needs to contain costs. I think the Ethiopian government, because as I told you, there are multiple questions of equity. Like in Ethiopia, we have geographic disparities. Like different regions have different access to the healthcare system, not only the service, but even for the physical infrastructures, including, roads to the healthcare system. And we have very different or inequitable health professionals. If you consider Addis, the capital city of Ethiopia, we have almost all, the specialists, and I mean the subspecialists, these days even the super specialists in the regions, so the Ethiopian government tried to, achieve equity in the primary healthcare level. That's why they have been working on this the health extension program, and the focus, even the financing focus, is on primary healthcare financing, because that's one of the most equitable way of providing healthcare service to majority of the population. If we are able to provide, the primary, if we are able to strengthen the primary healthcare system, we can at least achieve, equitable healthcare access to the population. So the government has been, providing majority of the budget to the primary healthcare system. Even it has been trying to expand, primary healthcare service provision in order to attain, equitable health service provision across Ethiopia. But still there are questions because, some of the regions are pastoral, some of the regions are agrarian, some of the regions are, urban and semi-urban. So there are multiple strategies that has been followed by the government in order to achieve, equitable health service provision in these all categories. So I would say the government has been, putting huge effort in the primary healthcare provision, because that's one of the most important entry point for, equitable health service provision. And these days also they are trying to make, these tertiary care services more equitable, because in many of the regions they are trying to have, tertiary.
Yeah, okay. Go ahead.
So you had about primary health care. That's I think the area which has been the government has been investing and implementing this primary health care system because that's really very helpful to attain equity related objectives of the health system. And recently, I think they are trying to optimize health extension program to the urban areas too. So I can say that's the area the government has been working to attain equitable health service access to the Ethiopian population.
Mm, wow. Yeah, we have a question from the audience which kind of aligns with what I wanted to ask you. So, I'm Amensisa Hailu.
Yeah.
He say thank you for the insightful presentation and talk. He says, what are the biggest research gaps in understanding health system resilience in Ethiopia that should be prioritized for the future? So, you know, research is data, and you did say most decisions should be, obviously decisions should be data driven, right? So how do you use data to inform health financing decisions at the policy level, and what has been like the biggest barriers for that so far?
Pardon? Can you repeat the question? You were lost.
um, oh, I'm sorry. Yeah, data is very important for decision making, right? So what has been the biggest barrier currently to data driven decision making when it comes to health financing? What challenge do you face now?
Okay, thank you. Thank you, Amina Sisa. I mean, I would acknowledge, Amina Sisa's point too. He's our staff now. He's studying his PhD in Australia.
Oh.
Yeah, as to the challenges with this evidence-based decision making, not only in healthcare financing but also in you know in general in the health system. you know Many of the developing country, including Ethiopia, we don't have sufficient quality data to make this evidence-based decision making. Even to conduct a research, we don't have secondary database systems in Ethiopia. We have had one database that was EDHS, the Ethiopian Demographic Health Surveillance, which was supported by the USAID. Currently, it's down. So I think one of the biggest challenges, we don't have sufficient data, and we are afraid even to rely on some of the administrative reporters of the healthcare facilities, because some of the administrative data are not convenient for research. But since we don't have any other option, where we are using those administrative data, and we are trying to collect primary data to conduct some sort of healthcare financing related researches. But even collecting primary data is very resource intensive, and we don't have sufficient resource. So in general, we lack quality data to conduct research, to provide quality evidence for policymakers. That's one of the biggest challenge. The next, even we did some sort of evidences. Some of the evidences are only for the academic purpose, since we don't have many policy related researchers. Majority of our papers are for the academic purpose, for publishing and for the academic promotion. They are not communicated to the policy makers. They are not translated to policy, and they are not in a way to challenge the government to change some sort of policies. So many of our publications, I know there are few publications that has been translated to policy related issues, but majority of our publications are for the academic purpose. And even if we have, some evidences that could be very helpful for, policymakers, the uptake from the policymaker side is very low. We have, some sort of gaps in the evidence generation and evidence utilization. So recently, we are working as a FNOT team and as, a researcher at the University of Gondar. We consider our service as, like a knowledge broker. We feel as a knowledge broker because we are working with the academicians or the one who is able to generate evidence. And now we are very close to the policymaker so that we try to bridge, that gap. So in the future, we need to have more knowledge brokers. We need to advocate, for evidence generation, but the evidence has to be, very quality, and it has to be used for decisions and other policy making. So there are three problems, as I mentioned. The first one, we don't have quality data. The second one, even those evidences are for academic purpose, not for policy change and other issues. The third one, there's a gap between researchers and policymakers, so that we need to improve the quality of data, we need to improve our evidences, and we need to bridge that gap. The knowledge has to be translated, the evidences has to be translated to policy making and other related issues. That's my understanding.
Wow. Yeah, thank you for that clarification. And it's very interesting to see. Uh, you mentioned very crucial points, right? It's the two bodies are completely separate, and I think in most of the challenge that we have in our healthcare system is the fact that there is no connection, and when there is an obvious interdependence but there is no interconnection between different sectors within that system, right? So that's very important, and I think that's what we face in a lot of other areas as well, not just health finance. um, and yeah, you should be applauded for trying to be the bridge between those two uh, entities that were supposed to be, working together, but apparently are not. So I love how you explained everything so far. I think anybody listening would have a better understanding of how things work and what are the real challenges. And I know it could sound very overwhelming. So, what advice would you give to emerging leaders who want to use, financial tools to create a resilient system? What would you advise them? Because it can feel very overwhelming, like you said. The problems are multifaceted, and the solutions are complicated and complex. So, what would you advise?
Thank you, Dr. Anania. Yeah, I mean, for emerging leaders and for young researchers in health financing area or health system, I think I would encourage them to understand the system. We all have something to feel in that system. That's a building block. The health system is a kind of a building block, so that anyone can put some sort of uh, block or some sort of stone in that to build up that health
Mm.
system. So I think, yes, I mentioned there are very multifaceted problems, but we still have the contribution to improve the health system. So I think at the very beginning we need to understand the system that we are working within. What's really how the system is working, because one of the traits, the leadership traits, as I mentioned, system thinking or strategic leadership is very important. Be it a research, you could be a researcher, you could be a healthcare professional working in a clinic, or you can be a policy maker working at the Ministry of Health, the Regional Health Bureau, or World Health Office. So but we need to understand, the system, the overall system.
Mm,
And even, the Warada is a very complex health system within the regional health system. The region is a very complex health system within the Ethiopian healthcare system. And the Ethiopian healthcare system is a very complex health system within the Ethiopian, federal arrangement. And the Ethiopian federal arrangement is a very complex system within the global, system. So that we need to understand our responsibility, and we need to be very clear in the systems that we are working. And we need to understand the systems are interconnected. You cannot change, one of the single point of, like, you cannot improve the healthcare system without improving the overall healthcare system of the country. So I think that the very beginning one, we need to be clear about the system that we are working. And as a researcher, we need to be very clear. We are here, to support, to improve the healthcare system that we are utilizing, that our families are, utilizing. I'm here, I'm a researcher, but the health system is for me.
yeah.
So we should be very responsible, and we should understand how the system is working.
Mm,
Then we need to have a very, clear goal within the system. We have our own goal, so that we need to understand our goal, and evidence are very important. So
mm,
we should think about, what kind of evidence is the health system really looking for, or what kind of evidence can I produce and can I give to the health system.
mm,
Many of our young researchers, they are, they are going for their PhD, their masters abroad, and they have been producing, we have been producing like 60, 70 publications. But we should sit and we should, ask a question: which evidence, which paper really contributed to the improvement of the health system of Ethiopia?
mm,
We should, start to ask ourselves. Otherwise, the country will not improve, and the health system will not be changed. So my advice is, I think we should understand the system, and we should understand, our, goal. And always it's good to use evidence, and evidence utilization and evidence generations are very important issues for emerging leaders and emerging researchers in the area. And we need to, interlink the evidence generation and evidence utilization. We need to fill the gap. That's my advice.
wow. Thank you. Thank you so much. I hope it sparks something in our, people listening to this and direct them to the right direction, because like you said, there's a lot of disconnects, and that's one of the it's also inefficiency. You do have a lot of
Yes, you're
data,
right.
but they're not practical data, or they cannot be
Yeah,
translated
yeah.
into real world. And yeah, so thank you for that advice. So my last question for you is, actually, it's not my question, it was from our previous guest on the podcast, and a phenomenal UK based orthopedic surgeon, a female surgeon, one of my kind of mentors, amazing woman. So she left this question for you. She doesn't know who it was going to be. She just left it for the next guest. It just happened to be you. So her question is, what is the most important lesson that you have learned from failure, and how has it changed your leadership approach?
It's a very, challenging question, because can you repeat the question?
What is the most important lesson you've learned from a failure? And how did that lesson change your leadership style or your leadership approach?
To be honest, I didn't remember, sort of failure in my leadership. But while, I went to South Korea, I was, my plan was to study health service management, not healthcare financing. But when I went there, Now, I was trying to find a professor in the area of health service management, and I failed to find, anyone.
Wow.
Then I decided to choose healthcare financing, and you know, I tried all my best to get, a supervisor in that area, and I found, one of the very renowned professor in health economics and health policy in Asia and across the world. And he gave me, one assignment to give him a very clear information about the Ethiopian healthcare financing system. I was not ready in that area, and I thought that he didn't have any information about the Ethiopian healthcare financing, and I create, some sort of information, and I provided that information to him. Unfortunately, he was an advisor to the Ethiopian Health Insurance Service, and he had, plenty of information. And he gave me that report, to read about Ethiopia, and that was really a turning point for me, to study about the Ethiopian health system and healthcare financing, and that was really, an exemplary time
Yeah.
for me, and I always remember that, and I always share that information to
Yeah.
others.
Wow. That is that's entertaining, but quite a learning experience at the same time. Yeah. It
Yes.
just goes to show you how
Yeah.
global this issue is, right? Just because you're in Asia or
Yes.
the US or Europe or Africa, our systems are so interdependent. And, that was very obvious during the
Yes.
pandemic, especially. It's quite a recent memory where how it affected everyone
Yes.
and
Yes.
everybody had to come together to come out of that, uh, an unpleasant experience. So I love that. I think we should really take it up on ourselves to understand other systems as well. To just be very good
Yes.
leaders, right? Knowledge is power. So the more
Yep.
knowledgeable we are, the
Sure.
more effective we're gonna be. Thank you so much, Dr. Asmamo. It has been great. Thank you for sharing that very personal but very very important lesson with us. And yeah, I'm excited to see the great things you're going to do for our healthcare system. And
Thank you.
I wish you best of luck. And probably I'll invite you again to discuss
Thank
more
you.
details.
Thank you,
Yeah.
Dr. Anania. Thank you so much.
You
Okay.
too.
Have a
Enjoy
nice
the rest
time.
of your
Thank you.
Sunday. Bye.
Okay. Okay.